Good afternoon, Chairman, Department of Surgical Disciplines, my seniors, colleagues, and residents. Today, from Department of Surgical Unit 2 from Department of Surgery, we are presenting our CGR on comprehensive colorectal services. Most of the time, whenever we talk about colorectal surgery, we often confine ourselves among the malignancies. However, today we will present our experience on different aspects of colorectal surgeries. Although it's a surgery to unit to CGR, but most of the cases that we have encountered or presenting today are done by me as well as our surgical team since from surgical unit 3 onwards. So practically it's a combined CGR partly with unit 2 as well as surgery unit 3. So with this background, I would like to invite my colleague, Dr. Aditya, to start with benign colorectal diseases.
Thank you, sir. Good afternoon, all. So the indications of ileocolic resections in benign diseases, we have categorized them into mainly three groups: tuberculosis, Crohn's disease, and a miscellaneous group that comprises of mainly perforations of the base of appendix and cecum or ascending colon, and also consists of colonic polyps and appendicular masses. However, for the next few minutes, we are going to focus on the other three groups, that is tuberculosis, Crohn's, and patients who had inconclusive or non-specific inflammation. Now, the indications of surgery in Crohn's and tuberculosis traditionally have been complications like intestinal obstruction, perforation, and in cases of diagnostic uncertainty. Recently, a failure of medical therapy has also been found to be one indication of surgery in Crohn's disease. Traditionally, when patients failed conventional medical treatment with steroids or immunomodulators, the next step was biological therapy. However, in 2017, this LYRIC trial was published in Lancet that included patients with active non-stricturing ileocecal Crohn's disease, which had not responded to at least 3 months of conventional therapy with steroids or immunomodulators, and the patients had a disease terminal of length less than 40 centimeter. The patients were randomized to receive either laparoscopic resection, ileocecal resection, or infliximab, that is anti-TNF alpha. The primary outcome was quality of life at 12 months, which was measured using the IBD questionnaire. Now, the authors found that there was similar quality of life scores in the two groups, and laparoscopic ileocecal resection was not found to be having more adverse side effects than infliximab. Also, surgery was found to be more cost effective, almost about 9,000 euros less than infliximab. Now, this is the 5-year outcomes of the LYRIC trial that was published again in 2020. And this showed that patients who underwent resection, about 22% of those patients did not require any further treatment of inflammatory bowel, any further medical treatment. And another 20% received no additional IBD treatment, but received prophylactic immunomodulator. Only about 26% of patients received anti-TNF therapy, which was required after a mean period of almost 2 years, compared to 38% in the infliximab group, where these patients continued taking infliximab, and almost 50% patients required surgery related to Crohn's disease. So the surgery was required almost after 1.5 years. Now, our experience is similar to what has been published in the LYRIC trial. So the patients we operated, the majority of the patients had presented with pain abdomen, and almost 50% patients presented with subacute obstruction characterized by vomiting and constipation. Now you can see that the most common site of involvement was the terminal ileum, IC junction, and the right colon. That is why its most common procedure performed was right colectomy in almost 90% patients. So this was right hemicolectomy in majority of patients, and in some patients we did a limited right colectomy, and 2 patients required extended right hemicolectomy. These are some of the specimens that were operated. This is a segmental resection of a terminal ileum where there was a stricture. One patient had multiple site involvement requiring a total colectomy. One patient had a left-sided involvement, and this is a limited right hemicolectomy involving the terminal ileum and cecum. These are the perioperative outcomes. Majority of the patients underwent laparoscopic surgery, and you can see that most of the patients had an uneventful recovery. Only 4 patients required a re-exploration. The post-op hospital stay was about 6 days. The patients who were re-explored, 3 were found to have an iatrogenic perforation, and 1 patient had post-operative persisting pain requiring diagnostic laparoscopy and peritoneal lavage. This is the final histopath. Majority of the patients had tuberculosis, 21 patients had Crohn's disease, and 2 patients were found to have malignancy. So you can see the patients who were initially diagnosed in the preoperative period as Crohn's disease, out of 70 patients, 13 were found to have Crohn's and histopath, and 4 patients were found to have non-specific inflammation. Patients who had non-specific inflammation initially, of them, 1 patient was found to have Crohn's, 2 were found to have tuberculosis, and 1 IgG-related disease. In the patients who had initially received ATT, 21 patients were found to have tuberculosis, 7 patients were found to have Crohn's disease on histopath, and 2 patients were found to have malignancy. So at a median follow-up of 17 months, overall 62% patients had a weight gain of around 6 kg, and of the patients who had Crohn's, who were initially diagnosed as Crohn's disease, majority of them had a good weight gain of around 10 kgs. So of the 17 patients of Crohn's disease, 5 underwent upfront surgery. So they did not receive any medication for Crohn's before surgery, and after surgery also they did not receive any anti-Crohn's any medical treatment for Crohn's disease. So 12 patients of these 12 patients who had received treatment before surgery, 10 received conventional treatment with steroids or immunomodulators or a combination of the two, and 2 patients received biological therapy. And in the post-op period, only 3 of these patients required further medical management, of which 2 patients had a dose reduction and 1 patient was escalated to biological therapy. So to talk about the medical perspective, I request Dr. Himanshu Naran from gastroenterology.
Thank you, sir. Respected faculty. So this is the therapeutic pyramid of medical management of Crohn's disease. So when a patient with Crohn's disease presents to us, we have to decide whether we have to follow the step-up approach or the top-down approach. The step-up approach is used for patients who have a low risk of progression, either elderly patients or those who have inflammatory phenotype or colonic disease. They are first managed with 5-ASA agents. If they don't respond, they receive steroids followed by immunomodulators. And if the disease is still refractory, then we give them biologics. However, if the disease is aggressive, like the strictures are there, fistulae are there, painful fistulizing disease is there, extensive small bowel involvement is there, upper GI disease is there, or the patient is very young, less than 40 years old, then the top-down approach is followed, that we straight away give biologics and subsequently add immunomodulators as well. These are the various biologics. The red ones are the ones that we frequently use in our OPDs and clinics. However, with multiple RCTs that have been done on biologics, we found that there is a therapeutic ceiling. Most of the patients who respond, usually around 60% patients are the ones who respond to any biologic, and in the rest 40%, we need to switch over therapy to subsequent line of biologic for their management. And herein comes the role of surgery, that patient is not responding to multiple line of biologic. When you operate them, inflammatory burden is removed, and then we subsequently treat them with biologics. Other indications, as mentioned previously, into acute indications like obstruction, perforation, intrapleural abscess, or intractable hemorrhage, or elective indications like localized ileocecal disease. This was a lyric trial. Then in small bowel medically refractory disease, in fistulizing disease, perineal fistulizing disease, and in dysplasia or malignancy. However, there is an issue after surgery as well, that there is post-op recurrence of Crohn's disease. So, at 1 year, endoscopic recurrence occurs in 30% of patients, which increases to 90% patients by 3 years. And 20-30 patients have clinical recurrence even at the end of 1 year. So what are the factors that help us reduce recurrence in such patients post-op? To assess this, we did a retrospective analysis of our old patients who had got surgical resection done from 2005 to 2021. And we looked at their follow-up and what were the factors involved. So in this recurrence-free survival analysis, we found that one, that performing surveillance endoscopic regularly, and based on that, guiding therapy with immunomodulators and anti-TNF agents reduced the risk of recurrence. However, when only 5-ASA agents were given post-op, then the recurrence was not reduced. Another factor that we found was that abstinence for smoking was also important. Those who smoked, they had a higher risk of post-op recurrence. Subsequently, studies have also come up. Like this was a meta-analysis of 6 studies, 1 RCT and 5 observation studies involving 4,500 patients. That if during surgery extended mesenteric resection is done, then the post-op recurrence rates reduce compared to limited mesenteric resection. In this meta-analysis, 5% to 15% was the surgical recurrence rates. So, from our side, when we stress like post-op, the patient should not develop recurrence. We have to do regular surveillance endoscopy every 6 months to 1 year. We have to give biologics upfront and ask the patient to stop smoking. And then now there's a role of extended mesenteric resection as well. Thank you.
So today we were discussing regarding the surgery in IBD and Crohn's and tuberculosis. But what I will do, I will take you through the diagnostic difficulties, what we primarily face on the biopsies, because not surgery is always performed, and that's why you are seeing some of the diagnosis was revised post surgery on vice versa. So take this example, we always mostly get a biopsy from the ileocecal region because it was mentioned this is the most common site of TB and CD both. So this is the ileum, and you can see in both the diseases we can identify patchy density of the inflammation and patchy distortion also, ulceration and some pale areas as you can see here. So this is the area you can see in comparison to this is more densely inflamed, as well as there is distortion, what we take as a feature of chronicity of the inflammation. So this is patchy chronic active ileitis, and I have already mentioned there are some pale zones and there is some metaplasia. These are actually Paneth cell metaplasia, which is also a feature of chronicity. So this is a chronic active patchy chronic active ileocolitis, and now we want to look at this area and reach to a diagnosis. So these are the areas which are important. Now before that, just a small few words regarding the Crohn's disease and tuberculosis. As has been mentioned, this is the most common site in both the diseases, and very commonly we get biopsies from the ileocecal region. In all of them we see very common features like patchy chronic active ileocolitis. You can see in all of them this is the cecum, and you can see the patchy nature of the inflammation. These are the activity. The ulcers can be deep in both the diseases. They can go through the muscles and perforate, though the perforation is more common, and fistula is more common in Crohn's disease. And in both of them, in the ileocecal region especially, we can identify basal plasmacytosis. Both of them can show dense inflammation to the deeper layer as well as stricturing fibrosis. So what are the features that can help us to make a differential diagnosis in these two? So one is identification of the large granulomas, and if we identify large granulomas, they are touching each other, which is named as confluent granulomas. And if we identify necrosis in them, then chance of tuberculosis is further high. Number of the granulomas are also important. In a single site biopsy, if you identify 5 or more deeper granulomas, then chance of tuberculosis are further high. Giant cells are more commonly seen in tuberculosis. So if we identify along with the patchy chronic active ileocolitis, if we identify all of the most of these features, then the diagnosis of tuberculosis can be favored. But in Crohn's also we know we can identify ill-defined small granulomas, which are called non-cryptolytic granulomas like this. But nonetheless, in tuberculosis also we can identify smaller granulomas, though there is some difference of the granulomas. They are more well defined, and we can identify ZN positivity that is defined. So what was the case? These pale areas, actually these are the large deeper granulomas with some necrosis. So in this case, we can make a diagnosis because we are fortunate that this area was sampled. Okay, so that's why even after clinical endoscopic and radiological correlation, we can reach to a diagnosis in 2/3 of the cases. In 1/3 of the cases, we cannot classify the disease, it remains unclassified. Now you can see this data of ours, you can see both macrogranulomas and microgranulomas can be seen in both Crohn's disease and tuberculosis, and the differential diagnosis, and the difference is not actually statistically significantly different. And this is another important thing, the diagnosis become more obvious obviously whenever you are doing a surgery and sending us the specimen, because now we can see the whole thickness, and if the granulomas like this are situated into the deeper layers and all other features I told, then the diagnosis is very clear. That's why If the biopsy is done from this area, we may not give you a diagnosis, that remain as unclassified. If the biopsies are taken in these areas, then it may be sampled and we can classify the disease for you. And it is also important, as and as the gastroenterologist always tell, that number of the biopsies is very important. In ileocecal biopsies, if you see endoscopic abnormality, at least 6 to 8 fragments needs to be taken, because more the number you take, then we see this type of granulomas. So this is just a small overview why the diagnosis changes sometimes after surgery, and what is the difficulty in the differentiating Crohn's and tuberculosis most of the cases. So, Dr. Manjunath.
Thank you, sir. I will be presenting on our data on carcinoma of colon. While colorectal cancers are the predominant one that we see, and the fifth most common cancer that is cause related, death related in globally is the colonic cancer. Incidence has reduced recently because of the intensive screening therapy. The diagnostic investigation of choice is colonoscopy guided biopsy. It also helps us to know whether the synchronous lesions. Apart from that, the CECT we tend to do to rule out the extent of organ involvement as well as the metastasis. The depth of involvement is what the T staging says about. And as far as once the N1, the N plus, the nodes are involved, the stage becomes stage 3. And whenever the metastasis is there, it is stage 4. Well, generally NACT is confined to those which are the adjacent organs or the bulky nodes where the unresectable or inoperable condition is there. As far as the surgical dissection is concerned, for the benign, we tend to stay more towards the colon. And when it comes to the malignant, lymphovascular excision, lymph nodal mass has to be removed. And whether it is D2 or D3 resection, I will be speaking in the next slides. Well, the high ligation is what we tend to involve. So, whether whether it is a D1, D2 or D3, it depends on the vessel ligation. Whenever we are dissecting along the SMA, it is D3, and when we tend to look at the pedicle like ileocecal pedicle, it is D2, and we are more away from that, then it becomes a pericolic. That's D1 resection. Margin, we tend to maintain about 5 centimeters on either side. Minimum lymph node resection is 12. En bloc resection if there is involvement of the other organs. And there are different approaches, whether it's a medial resection or the lateral resection. The types of resection in our unit, what we have seen from the data is many of them we have done is the right hemicolectomy or the extended hemicolectomies. The picture is all about where are we. This is the right hemicolectomy. This becomes the extended. This is the left hemicolectomy, including this one, and this is segmental or the transverse colectomy, sigmoidectomy, depending on the vessel pedicle that we are including. So most of the surgeries that we tend to do are the laparoscopic. We tend to pull the ileocecal junction and look at the arch on the mesentery. We open up the mesentery, then try to identify the duodenum. Here is what we are able to see the duodenum. Sorry, I'll begin again. We try to identify the ileocecal junction, then try to stretch. We identify the mesentery, open up that mesentery, ligate the vessel. Generally, the ileocecal artery tends to come here, and we'll ligate that. This video is edited, unable to see that. And then we identify the duodenum, then dissect the colon on either side. And once the resection is being done, then we begin with the anastomosis. Once the anastomosis is done, we remove the specimen from the suprapubic incision in a bag, so that we can avoid the infection. See, about the data, we had around 63 patients. Many of them are more than 40-year-old. As far as male and female ratio is concerned, it was more in the male, and most common complaint that they tend to come up came was the pain abdomen. Predominantly, the cases were CA rectum involved, CA colon that were confined to the ascending colon. The most commonly performed surgery was the right hemicolectomy and or the extended right hemicolectomy together formed the majority of the cases. While the extracorporeal and intracorporeal anastomosis, equal number of cases have been done. The surgical site infection was more common complication, and majority of them were had a minimal complication, that is Cleveland-Indo classification 1. Majority of them form the well and moderately differentiated adenocarcinoma. We had a follow-up among the 63 patients. Median follow-up was about 21 months, while mortality was only seen in 13% of the cases. The disease-free survival, it went up to it ranged from 1 to 82 months. I call upon Dr. Wasim to continue with the CA rectum.
Thank you, sir. I will be presenting the data on rectal cancer. Carcinoma rectum is one of the most common malignancies involving the lower GI tract. It involves almost 1/3 of the total colorectal malignancies. It commonly presents with painless bleeding, change in bowel habit, and tenesmus. Diagnosis is usually by colonoscopic biopsy, whereas CT scan and MRI pelvis help to stage the disease. It is mostly seen in the developed countries, and it is a disease of elderly, seen mostly in the patients more than 50 years. However, recently, in last few decades, the disease has changed its trend, and it is more commonly seen in young patients with a rising trend. It's more common in males, and the risk factors are like mostly 75% patients have sporadic disease, where 25 are familial with genetic factors, family history, and history of inflammatory bowel disease as a risk factors. It mostly affects the lower half of the rectum, that is the last 10 centimeter of the rectum and anal canal. MRI, as I already said, is the gold standard of local staging. It helps to identify the relation of the tumor with mesorectal fascia, which is the single most important factor while we decide to plan our management, whether to send the patient for neoadjuvant therapy or directly go for surgery, upfront surgery. It also helps to prognosticate the disease. So, based on the radiology in MRI, stage 2 onwards disease, that is T3 or T4, with or without nodal involvement, goes for NSCT and RT. The tumors which are in the lower half of the rectum respond very well, and are a standard. It is the standard of management to send those patients for neoadjuvant chemoradiotherapy. So, coming to the basic surgical principles, arterial resection after NSCT-RT or upfront surgery is the main target, with adequate margins. Margin proximal 5 centimeter, distal 2 centimeter in case of rectum, and high ligation of the inflammatory artery, clearing all the lymph nodes from there is the standard of care. So next coming to the concept of total mesorectal excision, removing the whole rectum, 2 centimeter tumor, 2 centimeter of rectum beyond the tumor, and removing the whole mesorectum with the intact fascia is called total mesorectal excision. It is the standard of care for management of rectal cancers. Now coming to the concept of sphincter preservation, if the tumor is directly not involving the sphincter or within 2 centimeter from the anal verge on the sphincter complex, all attempts should be made to preserve the sphincter. But if the tumor is involving the sphincter, it is within 2 centimeter, it is difficult to manage it, and we end up sacrificing the sphincter, performing an abdominoperineal resection. These are 3 photographs of 3 different patients. The first one, as we can see, we have patient has undergone APR with this is the pedicle inflammascentic vessel, and this is the skin and the external sphincter complex. This is another patient who has undergone salvage APR following a squamous cell carcinoma. Patient didn't respond to the treatment. We did a wide disease clearance, and this patient required a VRAM flap, vertical abdominal rectus abdominis flap, to cover up the defect. Whereas in this photograph on the right side, we could preserve the sphincter. This is the pedicle, and we could end up saving the sphincter complex. We remove the sigmoid colon and the rectum. So coming to our data, we operated 106 patients, and as we are saying, the disease is increasingly seen in young population. We had around 30% patients who are less than 40 years. Males were more commonly seen having C rectum. Bleeding PR was the most common presentation, and as we can see that among this 106 patients, 64 patients had a disease in the lower half of the rectum. Based on the clinical radiological findings, more than 80% patients are locally advanced patients, and 40 of them receive neoadjuvant chemoradiotherapy. This is interesting to note that out of 66 patients who had lower rectal cancer, 40 had locally advanced disease. Laparoscopic approach or minimal access approach is the standard of care now. It gives equal oncological outcome with less pain, early return to activity, and less hospital stay. Majority of our procedures are performed through laparoscopy and robot. Final histopathology showed majority of patients having adenocarcinoma, except 6 patients who had malignant melanoma, and 2 patients underwent APR for squamous cell carcinoma. We had a CRM positivity rate of 9.4%. With a median follow-up of 36 months, we could follow up 65 patients as a whole. There were 2 patients who had local recurrence. Distant failure, distant metastasis was seen in 14 patients. Mortality over a period of 36 months were 12. And disease-free survival was almost 4 years. It is interesting to note that in spite of having CRM positivity in our series, it has not any effect on the local recurrence or the overall mortality of the patient. For the next session, I would like to ask Dr. Prasanna to present on pelvic floor disorders.
Thank you, sir. Good afternoon to one and all. So let's go ahead with the pelvic floor disorders. So a brief anatomy of the pelvic floor. It is a dome-shaped muscular sheath that predominantly contains the striated muscles, which mainly is formed by the levator ani complex and the coccygeus muscle. So the main functions of the pelvic floor is to support the abdominal viscera, including the rectum, and also the continence mechanisms of the urethra, anus, and all the vaginal orifice in the female. So there is a spectrum of pelvic floor dysfunctions which can occur. So we will be concentrating mainly on our patients, which mainly are the colorectal patients, especially the rectal prolapse patients. So this is the photograph of a rectal prolapse patient. It can be a devastating disease for the patients themselves. So coming to the etiology, it's exactly not known. So most causes include obesity, postmenopausal patients, post-pregnancy and childbearing, and some collagen abnormalities, sexual abuse, and poor defecatory practices. And the mechanisms include the chronic straining and redundant sigmoid and the pelvic floor muscle weakness. So for clinical evaluation, the history and physical examination is the most important, but to support the diagnosis and also to rule out other causes, we have various investigations like the anorectal manometry, which gives us the resting pressure and the squeeze pressure of the anal sphincter. The balloon expulsion test, we don't do it regularly, but if it is done, it indicates if it is positive, that is, if they cannot expel the balloon within a minute, then it would suggest an associated defecatory disorder. Then the endoanal ultrasound can help us assess for sphincter pathologies, and the defecography is said to be the gold standard, and it gives us idea about the presence of rectal intersusception, any pelvic floor descent, and functional problems like the puborectalis dyskinesia. So nowadays MRI is also replacing the defecography, so it is similar to the standard defecography. And of course, colonoscopy can be used to rule out other pathologies which could be associated, like the SRUS. And CT, MRI, and pelvis may be used if there is suspicion of any other disorders along with this. So this is the anomanometric testing, where a probe is inserted and the readings are obtained. And when the balloon is placed, then the expulsion test can also be done. So this is just a photo of the defect program, which will be covered.
So coming to our experience, 61 patients in total had pelvic floor disorders. Majority of them were of rectal prolapse, that is 56. Two of them had obstructive defecative syndrome, and chronic constipation was seen in 3 of the patients. So we had follow-up of 50 patients. Coming to the procedures done, majority of them underwent Delorme's procedure, which is 40 of them, and ventral rectopexy was done in 12, of which 5 were robotic, and Thier's procedure was done in 3 of the patients. Altamias in 2, and a combination of Delorme's and Thier's was done in 1 of the patients. So the videos here on the left, we can see the Delorme's procedure, which is the perineal, most common perineal procedure performed in patients with rectal prolapse, and on the right we can see a robotic ventral mesh rectopexy being done. So in Delorme's, we are marking the mucosa to be resected. So the mucosectomy will be done, and the musculature is plicated so that the descent is. So here we are doing the mucosectomy. Once the mucosa is resected, the plication sutures are placed all around. So once the sutures are tied, and once it's released, the rectum regresses back. So here the mesh was placed, as you could observe, the mesh was placed after dissecting the rectum and mobilizing the rectum, and the peritoneum was closed over the mesh. So this helps to anchor the rectum to prevent the prolapse. So coming to the baseline data, mean age of the patients were around 40 years, and we had a mean follow-up of 38 months, and ranged from 4 to 84 months. And the mean baseline Wexner score was around 4.78, which reduced to 1.36 in the follow-up. So rectal prolapse was, so in the baseline deficogram, we could see 62% patients showing rectal prolapse even on deficogram, while funneling or intersusception was seen in 11%, rectocele in 9%, and descending perineum was seen in around 1.4% patients. In pubic puborectalis dyskinesia was seen in 7.8% patients. In the baseline manometry, 43 patients could undergo manometry, and in those patients, 56.8% patients had a low resting pressure, and squeeze pressure was low in 51.7% of the patients. So coming to the resolution of symptoms, majority of the symptoms improved. So in fecal incontinence, it reduced from 34 to 20%, while in constipation also, there was significant reduction in bleeding and straining also. However, manual evacuation and laxative use, those patients who had them did not show that much of an improvement. So coming to the recurrence rates after the procedure, major recurrence was seen in 4 of the patients, and minor recurrences were seen in 7 of the patients. All patients with major recurrence were reoperated, and after that they presented with a minor recurrence, but it was not as bad as before. So older patients tended to show recurrence after Delorme's in our experience. Coming to the complications, 2 of them had rectal stricture, which resolved after serial dilation, and bleeding was prolonged in 1 of the patients, which continued up to 3 months, which resolved again after conservative management. And rectal ulcer with pus discharge was seen in 1 of the patients, which required an Altamias procedure, and he resolved after that. And 1 patient died, but it was not related to the surgery. So a brief literature review, this paper by Emily et al. Shows recurrence rates of, according to them, was around 8% in their paper. And similar recurrence rate like 12% was seen in paper by Senapati et al. And so this is similar to our recurrence rate, so around 19%. After this, I called Dr. Vinamrita for discussing the radiology of rectal prolapse.
Good afternoon, everyone. So today I will be talking about the use of imaging in case of suspected obstructive defecatory syndrome. So there are primarily 2 things which we do. One is the barium conventional defecography, and the other is the MR defecography. Now to start with the conventional defecography, what we first do is we obtain a plain film in lateral decubitus position. Then we instill 20% barium per rectally and take 4 subsequent phases. That is the rest phase, the squeeze phase, the strain phase, and finally the defecatory or evacuating phase. We evaluate 2 things primarily. One is the pubococcygil line, which we take from the tip of the coccyx to the lower border of the pubic symphysis, and the other is the anorectal junction, So line is from the anal canal and the posterior rectal line. This angle we also measure, that is the anorectal angle, and we see the anorectal junction over here. In normal rest conditions, the anorectal angle should be 90 to 95 degrees, which shows normal descent in the strain and the defecatory phase. We can also assess the impression of the puborectalis sling. Another thing which we see is the anterior rectal line, and the bulge of the anterior rectum should be less than 2 cm from it normally. So these are the phases: the resting, the squeeze, the straining, and the evacuatory phase. The angle should never increase more than 135 degrees. Now we look at a case of a 60-year-old female with history of hysterectomy 7 years back, complaint of constipation since then. On the resting phase, what we can see is, this is the anorectal junction and this is the PCL line. So on the resting phase itself, the anorectal junction lies 3.6 centimeter below it, and the anorectal angle is 131 degrees, which is significantly high. On the squeeze phase, there is mild decrease of the anorectal angle. On the strain phase, there is further descent of the anorectal junction, and the angle is 123 degrees. And the similar finding is the defecatory phase as well. We can also appreciate this rectal bulge anteriorly. From the anterior rectal line, this measured 2.5 centimeters, so hence it is a mild anterior rectocy. So the final impression is a low-lying anorectal junction with descent and anterior rectocy formation. Now we look at the dynamic MR defecography, and where is it done? It is done when detailed assessment of soft tissues and dynamic pelvic floor function is required, particularly if there is suspicion of pelvic floor disorders, and anal sphincter status has to be known. In dynamic MR defecography, what we do is, the additional benefit is we can assess the anterior compartment, the middle compartment, as well as the posterior compartment, which we could not see on the conventional defecography. We also assess two more lines, except the PCL line as well. One is the M line, which is the line from the mid of the PCL line to the anorectal junction. This is the anal sphincter, the internal anal sphincters, and the other is the H line. H line is from the inferior pubic symphysis to the inferior point of the M line. This is the hiatus line, which depicts the levator hiatus. It should be normally less than 5 centimeters. Now we will see the case. A 70-year-old female with history of chronic constipation since 2 years. She also had history of urinary incontinence and feeling of something coming out of the vagina. Now on the resting phase, what we see is the M line measures 1.8 centimeters, which is normal. The anorectal angle is 88 degrees, which is also normal for this phase. On the squeeze phase, there is decrease of the anorectal angle. But on the straining phase, we can see that this is the M line, which has decreased. The anorectal junction and the rectum is descended and now has become 3.9 centimeters. There is also descent of the vagina and minimal descent of the bladder neck, which is further exaggerated on the defecatory phase. This is the bladder neck. We can see a small cystocele formation, and the anorectal junction is now well below, that is 4 centimeters. So on final impression, this is a case of descent of anorectal junction with vaginal prolapse and cystocele formation. So both these investigations, that is the conventional and MR defecography, are extremely useful to evaluate in such cases. However, there are certain pros and cons. In the conventional cases, the pros is it is done in a squatting position, which is natural for the patient and it is less expensive. However, we are unable to evaluate the status of anal sphincters and the pelvic musculatures accurately. In MR defecography, these cons are overcome, but it is done in a supine position. To again emphasize that MR defecography is very important to assess the anal sphincter complex integrity. Thank you.
Thank you. Thank you. So now I will take you few journey of ours on few rare diseases and few novel procedures that we have undertook in the last couple of years. So I will shortly go about these procedures. Arteriovenous malformation of rectum is a rare cause of painless bleeding, and often these patients are misdiagnosed as a case of hemorrhoid or other not irregularly occurring causes, and their management and ways of are not standardized, and literature is also scarce about their exact management. Different type of management has been seen, vascular from vascular embolization, sclerotherapy, radiotherapy to surgical resections. Out of the surgical resections, abdominoperineal resection has been the standard and still practiced. However, although it gives good success, but it is a morbid procedure, too radical for a benign disease, and that too for a young adult. So we initially conceptualized that since these vascular malformations are arising from mesodermal tissues, they would be confined to rectum and mesodermal tissues. With that principle, we hypothesized that a total mesorectal excision along the embryological plane between the mesoderm and ectoderm would suffice as standalone treatment for it and will give us complete excision of the mass along with good outcome for the patients. So as you can see, this is one of the pictures of a vascular malformation. Entire mesoderm is studded with blood vessels. However, there is a plane outside the mesoderm along the rectum. So we propose that total mesorectal excisions in this line would give us a complete excision of the mesoderm and the lesions without compromising the sphincter function. Here we are doing a resection on the embryological plane, and these are the spicules of the hemangiomatous plaques. So those hemangioma are confined inside the mesorectal tissues, and we could identify that embryological plane safely all along the mass and mesorectum. So you can see these are the hemangiomatous plaques. They are still confined to the mesorectal tissue. With that precise and technically possible dissection, we dissect it out till the pelvic floor. Once we come to the pelvic floor, then rest technically is the same. Then we come out and from the intersphincteric resection from the perineum, and tumor has been, then the whole hemangiomatous tissue along the rectum is delivered to the perineum, and we do a colorectal anastomosis. So this was, and that gives us complete excision of the malformation with sphincter preservations. We have done till now 3 cases. This technique has been already published. One of our SR2 presented this case in the European Association of Endoscopic Surgery conference. And now it has been accepted. We have done 3 cases with good outcome. Another condition is fecal incontinence, which is not talked much about, but it is often exists, and it is a bothersome disease for the patient. Exact treatment is not really known. There are various different types of treatment has been proposed, starting from stoma till different type of perineoplasty, basilostomy, etc. In 1995, another modality of therapy was proposed, that is sacral neuromodulation. Initially, this was done by open technique, but with the advent of radiological intervention in advanced radiological screening modalities, it can be now done with minimal invasives. And at the moment, sacral neuromodulation or sacral nerve stimulation has been the first line of therapy for surgical therapy for fecal incontinence. And we could offer, and here in this technique, electrode is placed under radiological guidance for the S3 foramina, which continues to give the impulse, like in case of pacemaker for cardiac purpose. So this is how patient is done. It's done under local anesthesia. Needle is placed on the from the sacral area, and it is done under radiological guidance. So under fluoroscopic guidance, the catheter is placed in the sacral 3 foramina so that it constantly gives impulses to the pudendal nerve. And during the procedure also, it is feasible to highlight the activity of the sphincter. As soon as we started the producing the impulse, there is inherent contraction of the sphincter muscle. So that's the sacral neuromodulations for fecal incontinence. And we have done 2 cases who has completed the therapy, and at the moment their outcome is really gratifying and they are improved quality of functions. Incidentally, AIIMS is the first center in our country to start sacral neuromodulation program for fecal incontinence. We also had the opportunity to start different type of transanal procedures, transanal endoscopic microsurgery as well as TAMIs. In transanal endoscopic microsurgery, under endoscopic guidance, intrarectal lesion is excised. And this is how it is done. The whole system is inserted, and under endoscopic guidance, the lesions from mid and upper rectum can be excised very satisfactorily. Initial experience of TAMIs, we now gone ahead with transanal endoscopic minimal invasive surgery, which is also known as TAMIs. which is a more flexible platform than the original TM. Here we insert the tummy platform inside the rectum, and once it is inserted, the faceplate is fixed with the anal skin, and the obturator is attached, and then under we do same way as we do laparoscopic surgery, and the under laparoscopic guidance, the tumor can be visualized intrarectally. This is the intrarectal tumor at around 7 centimeter from the anal valves, and this can be excised surgically with very precisely with rigid instrument. That is TAMIS, or transanal minimally invasive surgery. So once the dotted safety margins are defined, then complete thickness excision of the tumor is done all around. First, we divide the rectal wall. Once rectal wall is transected, we then proceed to excise the tumor from the mesorectal tissue. So here you can see the tumor is here, and it is lifted up with the mesorectal instrument from the mesorectal tissues, and the tumor being separated from the base. Once tumor is completely excised, it is removed from the rectum, undivided, unfractured, and finally the whole defect which was created while in an attempt to remove the tumor is closed surgically. These are surgical sutures done by surgeons very comfortably with regular laparoscopic equipment. So this is TAMIS, and we have done a couple of cases with TAMIS. And the beauty is that it gives us a completely unfractured lesion with good margins and with adequate safety precautions. Also, on those patients where TAMIS cannot be performed, mainly those are located very close to the anodrome, with the use of this typical retractor, those tumor are also now can be excised very safely under local or magnified visions. So this is called local excisions. We have done a couple of cases of local excisions for all those specialized tumor located just above the anal valves with adequately optimal results. So this was about, and then recently there is a new technique called transanal total mesorectal excision, where mainly for male patients or tumor located very lower down, tumor is addressed from the inside the rectum. Instead of going from the abdominal approach, we come through the anus, dividing the rectum, then going out to the perirectal tissues and removing the whole rectal tissues from the anus. This is a new type of procedures for lower rectal or cancers, and we have a couple of cases have done safely using this technique also. Here you can see the tumor rectum is removed from the anus, and subsequently we anastomose with the rectum. So we have done a few cases for transanal total mesorectal excision also. There is another entity, rectovaginal fistula, is often difficult for the patient, as well as it's difficult to treat. Traditionally, it is approached either by the abdominal approach or by the transperineal approach. However, there are few sets of patients where tumor lesion is located just around 5 to 6 centimeters from the anal valves. Those are difficult to access either from the abdominal approach or from the perineal approach. In such tumor, we have developed a new technique, name it as a minimally invasive transanal repair or MITAR technique for such fistulas. So this is one of the cases we developed rectovaginal fistulae after a low rectal anastomosis. You can see here is we are now inside the rectum, going through under endoscopic visions. Here is the wasp is placed in the vagina, and here is the rectum. So, and this was the rectovaginal fistula. Whole rectovaginal fistula then mobilized along the rectovaginal septum under magnified vision from the transanal endoscopic microsurgery platform. This platform allows a very standard and stabilized platform and magnified view for mobilizing the rectovaginal septum. So once the rectovaginal fistula mobilized, you can see the cervix from the vaginal or from the rectum. Then we first close the vaginal wall from the transanal sutures. Once it is closed, we checked the vascularity, first the closure adequacy, then also the vascularity of this closure. once the vascularity enclosure is adequately confirmed, then we close the rectal wall in a similar fashion. So this is at the end of the procedure, the whole fistula is repaired, and this is a subsequent X-rays of the same patient. There is a complete healing of the fistula. We have done this meter technique for 3 cases till now. With the results are successful. At the follow-up of at least median of 1 year follow-up, there has been no recurrence. Another disease spectrum that we have touched upon is adult Hirschsprung disease. Hirschsprung disease is a disease of infancy. However, in certain group of patients, we do see Hirschsprung disease in a very adult life also. The traditionally described procedures, either Swenson, Duhamel, or Soave, are difficult to adopt or in adult patients because of large and high and pelvic cavity, as well as because of the hypertrophic muscles. So you can see this is a case of adult Hirschsprung disease. The sigmoid colon is so not only distended, there is extensive hypertrophy of the muscles. This is the collapsed rectum. So we developed a new technique called MECA, where we do the procedure in 3 different steps. First step is to perform a divergent stoma. Then give adequate time of intervals for the stoma to decompress, as well as muscle fibers to decompress to some extent. Then complete mesorectal excision and coloanal anastomosis. And then once coloanal anastomosis is done and hold the agalenic segment is excised, after around 3 months of time, we restore the vascular coloanal anastomosis. So this is MECA, and we have performed 3 cases of these procedures. In 2 cases, we have reversed the stoma, their continence has been restored and constipation has been improved, while 1 patient is still waiting for ileostomy reverse. We have also touched upon anorectal disease, various spectrum. The number is small, but we are growing on. So in last almost 1 hour, I have given you our experience mainly on diverse spectrum of colorectal disease, not only on malignancy, but benign as well as other coloproctological issues. And we are trying to initiate this trial. In this process, we have also organized 2 workshops, AIIMS Coloproctology Symposium, ACS, in last year, as well as this year, which try to give us different spectrum beyond malignancy among the colorectal surgeons. We also have few publications on this disease with various, along with other department faculty members. And to conclude at this point, I would like to acknowledge Professor Sunil Shumba sir. Actually, he is the brain behind starting the AIIMS Coloproctology Symposium, which we started 2 years ago and successfully done this time. Professor Rajendra Prasad sir and entire faculty as well as residents of Surgery Unit 3, as I already described, these cases primarily we did along with him in Unit 3. Then Professor B.K. Bansal, who is my mentor as well as our mentor to my faculty colleague, who has always been a guiding force for all of us. Professor N.R. Das, who helped us to initiate the vascular malformation cases to begin with, and he helped me personally in our OT. Then Professor Binish Ahuja sir, who helped us in establishing the laparoscopic surgery for inflammatory bowel disease. I also thank the Department of Radiology, Department of Radiotherapy, Medical Oncology, Professor Subhas, who has been always helpful to us, giving radiotherapy to our rectal cancer patients. Department of Anesthesia and Critical Care, who have been instrumental in taking care of all our patients. Department of Pathology, to provide us all diagnosis. Often we talk them over phone, and doctor is always eager to help us in whatever way it is. And at the end, I would also like to thank all my residents of Department of Surgery Unit 2, Department of Surgery. They have been the main guiding our hard-working force for this CGR. Last almost 1 week, they have been working very hard to get all this data from our database. Thank you to all. With this, I would like to open this podium for discussion. Sir.
I think we must also thank the Department of Anesthesia, without whom we could not have completed. Congratulations.
Yes.
Yeah.
Thank you, sir. Sir, maybe.
First, congratulations to Dr. Emma. In colorectal, there are certain things which are easy to do. Patients can perform with hemicrectomy, anterior resection. The challenge lies in clear, particularly the electrodes. Because actually last 50 there are about thousands of patients. Because none of them is very important to understand the problem and then maybe individualize the treatment. So many activities. And I think with the focus, concentrating on these other activities rather than the importance and concentrating was very important for me. Often neglected and because there is no clear and to have a focused attention to the will help, not only the patient but will also help our own understanding. And with respect cross the one thing I noticed from the communication that I mentioned where recently section is also showing better results, but the general incident one has been that is what we have shown here. And when we talk about the one thing that has happened, the classes are nobody wants to do 6 classes, there is so when we used to do this, we used to do a lot of because conservation was the key in this. We conserve because we never know which part of the problem we are affected. If you go to a lot of recently, you have to take a lot of time. Because if you take that much of exactly, a lot of problems will be. So I don't know how that will bring us a foolproof medical treatment like okay, nothing will happen again. It still would be very reluctant to go on to very guidance. These words that cannot be made of taking up some of the areas where we so far here.
I have one question. One is ensure that entry the after surgery. So what are the
So, yeah. Actually, we do a trial where upfront surgery or software 3 months of initial care of management. All 3 cases have only received only steroid. 2 cases received steroid, there are more still progressive disease. And one case we started because it was isolated ileocecal lesion in ileocecal bones, and we did segmental ileocecal. So there are 3 cases that we did from surgery. They are now doing.
I think another issue was you have only 10 cases of that CRI positivity. Our status only 10 patients.
Yeah.
That's why possibly this is not showing you significant.
Maybe yes, but while reviewing the R1 possibility, because also we need also to understand that these are advanced growth. Almost most of them are 3-4 growths, and 3 of radiography shows, sorry, 3 of MRI almost shows CRM positivity upfront. We gave them radiography and all systems opted for surgical incision. So 3 of them turn out to be R1 or margin positive. Other didn't translate to local recurrence. So all those patients, only one of them had local recurrence, but they had distant recurrence. That's why they are almost all of those had actually distant recurrence. There are quite a number of patients, almost 50% had distant recurrence. So, yeah. Most of the cases, yeah. So most of the cases for laparoscopy on the right side because the right side is only to see more. then Crohn's is difficult dissection surgically than malignancy. So when we started Crohn's for surgical treatment for Crohn's, all right-sided we have malignancy, so we did right-sided dissection laparoscopy. First two cases initially because of the documented difficult, we started left side authentically, but later on we now started doing laparoscopy for left as well. So both right to left, all the distance laparoscopy first option, other than difficult, conversion rate is also more than on malignancy.
More easier than the right side. Therefore, as far as the vessel pedicle is concerned, hemovenous is concerned, and the most worrisome vessel is the gastroduodenal artery, epidural artery, etc. Which is more. So, left side is more important.
Those who are CRM positive, but already
All is seen.
radiological and preoperative environments have been done both.
Yes.
For the cases where radiologically it was like not expected to have CRM positive, but later on.
Yeah. So almost either they are hidden CRM or T3B or T3C lesions. So all that we see in radiotherapy, post radiotherapy, they are margin of negative. Surgical decision, they are not big.
Now your question why part number 2? When you are only
Sorry? Sorry?
only one part for this one.
Yes. Actually, we have started so number of patients.
Maybe the same CRM positive because they would be advanced for approximately 80 years.
Yes, yes, almost 80. No, actually, very advanced, that means both upper rectum, middle rectum, lower rectum. So only middle and lower rectum is sent to you. Upper rectum is with optimal surgery. Out of all 80%, maybe around 40 actually are middle and lower. Maybe around 82% of those middle and lower receive neoadjuvant. Yeah, retina file is very different from what we read in books. People say. Years ago, I got some people was a resident with us. At that time, we had analyzed data almost 100. 80% of them are lower applicants. One and middle, and they are huge sense. So, whereas that, I think 10% CRM possibility is quite a commendable thing. Not say that. Because you do everything, most of them have yes. Yes, of course. Recently, the issue was so hard. And then once they got to the bottom of it, like, what is saying? The saying says, we not reduce fire. So these stakeholders will pay. Refuse fire. So they can very well that and I think they got every day that and we have here the median was 43 years. So I think they are different. If there is no more comment or suggestion, then I would like to conclude this video. Thank you.